Welcome to the AUA Leadership and Business Podcast, where urologic professionals experience the practical application of business acumen essential to successfully navigating today's rapidly changing business environment. Thank you for joining us, and we hope you enjoy this episode.
Hello, I'm Dr. Jennifer Miles Thomas. Today, we will be providing an introduction to relative unit value and its importance for both reimbursement and physician compensation. So I am very excited to have with me today a true expert on this topic, Dr. Thomas Turk. Dr. Turk is a professor of urology at the Loyola University Medical Center, where he also serves as the endourology fellowship director and has a full-time academic practice. His research interest is primarily in the metabolic stone disease and its effects on renal function and kidney stone formation. He currently serves as a member of the AUA RUC Advisory Committee and AUA's Coding and Reimbursement Committee. Welcome, Dr. Turk.
Thank you very much for having me.
Perfect. Well, of course, physician compensation, the way that we're paid, the way things are coded, all of our compensation models sometimes involve RVUs, but I don't know that everyone really has a good understanding of what it means. So, to set the stage for this discussion, can you kind of provide our listeners with an overview of RB, RVS, and RVUs?
Sure, I'll do my best. So, I think all urologists on the call are familiar with CPT codes, which stands for current procedural terminology, the 5-digit code that we all live by. Now, for when we do procedures or we see patients in the office. Now, all CPT codes have an associated value, and that unit is the relative value unit. The idea that it's relative, so a relatively simple thing, for example, a cystoscopy, has a lower value than a more complex procedure like a radical cystectomy. So the idea that there's sort of a hierarchy. This system called the RVS, which stands for Research-Based Relative Value Scale, has a fairly long history. Started back in the mid-'80s when Ronald Reagan was president. And it started at Harvard University, and they started to assign values to different procedures. And it's across medicine, not just urology. I think it started with general surgery and then spread out and tried to encompass, kind of all the procedures of that day, office visits, and that sort of stuff. Now, things have evolved over time. In '89, under President Bush, payment started to be based on the relative value. And it evolved that the unit became the relative value unit, or RVU, which is a term most people, I think, are familiar with. And then in 1992, Medicare sort of incorporated RVS and RVUs into the system. Now, there's three important components to any RVU. There's the physician work, which we all are familiar with what we do, and that represents approximately 48%. There's the practice expense, which is another 48%, and that encompasses things like having an office, right? You have to have an office to do a procedure. You have to have a nurse. You have to have a receptionist. You have to buy supplies. You have to buy cystoscopes, things like that. And so you need to be paid for that. And so that represents approximately half of an RVU. But then the final part, which is PL, stands for professional liability, and that's a relatively small fraction, approximately 2%. Now, this whole system is administrated by what's called the RUC, which is the RVS Update Committee. Everybody calls it the RUC, RUC. It's a committee that was established in 1991, and the AUA has been involved since that day. Dr. Bill G., who's still involved with it, was involved from day one. And the RUC meets 3 times a year, twice in Chicago and once in a warmer place in the wintertime. And in that committee, we or the committee places value or relative value for different CPT codes.
Hmm. So, in this committee meeting, so what is the process? Like, how do you guys determine the appropriate value or the RVU for a physician's work, since there are so many different CPT codes, so many different services we provide?
Right. So there are thousands of codes. If you've ever looked in the CPT book that lists the procedures in the different code numbers, there literally are thousands of codes. Now, many of those have their original value that was determined by Harvard University. But as things have evolved, there's of course have been new procedures. New procedures have been invented, new devices, lots of different things in urology, for example. Um, so the impetus to value a code can come from different places. It can come from CMS, Center for Medicare and Medicaid, that says, hey, we need you to evaluate this code. For example, if the code is being done in a different place. For example, it may have been an inpatient code where people stayed in the hospital for a week, and now it's an outpatient code. For example, prostatectomy is an example of that. And they'll say, you need to revalue that code. Or there can be a brand new code there's a whole nother committee called the CPT committee that assigns CPT numbers in for new codes. And then if there's a new procedure, it needs to have a value. So that goes to the RUC as well. So most of the things that we're asked to evaluate, for example, the AUA, they tell us to, in essence, either the RUC does. And one thing I didn't mention, which I should have, is the RUC is really an advisory committee to CMS, and it makes recommendations of value that it reports back to CMS. But the ultimate decision resides with CMS. For example, they may say, okay, we agree with the RUC, and that's what the value is going to be, or we think that the RUC gave a CPT code too high of a value, and they can lower it down. Now, there is sort of a complex appeal process, but really the ultimate decision resides with the RUC. Now, the RUC is composed of, it was formed in 1991. It's administered by the AMA. As I said, it provides recommendations to CMS, and it has 28 voting members. And there are members from lots of different medical societies, for example, AUA, and we have a permanent seat. ACOG, American College of Obstetrics and Gynecology. When you look up the makeup, it's approximately 2/3 what I would call kind of medical specialties and 1/3 surgical specialties. And as I said, the CMS will typically ask the RUC or to ask us to evaluate codes. And then we look at all different aspects of it. We send surveys to our membership, and hopefully many of the listeners have gotten surveys and have answered them. And you're asked to provide information in terms of pre-service work, intra-service work, and post-service work. So obviously it takes, for example, a surgery, it takes work to get a patient to the operating room. The operation itself takes work. And then after the operation, it takes work. You have to write prescriptions, you have to call primary doctors, that kind of stuff. So the idea is to try to determine each of those components, how long it takes and how intense it is. I would argue that doing a cystoscopy, for example, is less intense than doing a radical cystectomy. So the intensity is higher, and so you can make the argument that the value should be higher, even for the same amount of time, if that makes sense. That for a more difficult procedure, it should have higher value than a less intense value. Now, you'll notice that I haven't mentioned money. And values there's no dollar figure attached with any of this. And this just determines value in relative value. Payment per RVU is kind of a whole nother thing.
Well, that makes sense. Can you just briefly talk about the importance of surveys? I know that I've seen a couple of surveys coming in through my email, but what happens if we as the urologist don't fill out the survey?
Yeah, so the expression those of us on the committee say is we live and die by the surveys, meaning if we have a robust survey, and there are some minimums, it depends a little bit on how often the procedure is done. But for example, the typical minimum is 30 surveys. Now, the AUA will send out surveys oftentimes to 5,000 members in a random basis. Now, if it's a brand new procedure, something that very few people do, we can obtain permission to send sort of what we call a targeted survey. Or, for example, if it's a procedure done by predominantly urogynecologists, we can get permission to survey the urologists in that society, for example. But hopefully most of the members of the AUA have received surveys, and they are absolutely crucial. And they don't take all that long. And I know we all get a million emails and are probably asked to do lots of surveys, but I would argue these are some of the most important surveys. And it will ask, just sort of what I alluded to, it will ask the work involved in the pre-service work, getting somebody ready for the operating room. Things like, how long does it take to position? For example, putting somebody in a lithotomy or a prone position may be more difficult than in the supine position. How long the operation takes, and the urologists completing their surveys will be given the opportunity. They'll have other codes presented to kind of say, well, this procedure is like that procedure, it's easier than that procedure, or it's harder than that procedure, to try to give a sense of relativity. And we choose codes that hopefully most people are familiar with. Most of them are urology codes, but not always. With the idea that you can say, well, where does this particular thing fit into the hierarchy? Is it easier than that? Is it harder than that? So the surveys are sent out. Hopefully we get at least 30 back, and hopefully we get hundreds back. And then all that data is tabulated. And then we fill out what's called an SOR, or summary of recommendations, that we send in advance to the RUC. And then at the RUC meetings, we basically present the survey data and say, well, this is what urologists, this is how long they say the procedure takes. This is how they say what the work beforehand, and this is what they say the work is afterwards. And the more surveys we get, and most of our surveys are very tight, meaning the numbers are very similar, you get a lot more buy-in. The committee says, well, gosh, if 100 people say that, it's better than if 10 people say that, right? So the more surveys we get back, the more believable things are. Fortunately, we typically have good responses. Now, it's a little more complicated if you have a brand new procedure and only a handful of people do it. It's harder to get big numbers, in which case there's guidelines that allow us to have fewer responses.
All right, that makes a lot of sense. Well, one of the things you mentioned is that, RVUs are not cash, right? So if we move from RVUs to payment of service, what should physicians know? What are the key differences to consider?
So there is, in essence, a conversion factor, but there's a couple of components to it. So as I mentioned before, the RVU has three components: work, practice expense, and professional liability. And the work and the practice expense are relatively equal, almost 50% apiece. And so the sum of those three things are multiplied by what's called the GPCI, Geographic Practice Cost Index. Basically, the idea behind that is the price to practice medicine differs depending on where you live. For example, if you work in downtown Chicago, it's more expensive to practice medicine because you pay more for rent. For office rent, you probably have to pay your nursing staff more than you may pay in a rural area. That is kind of a fudge factor, or an adjustment to what the value is. Okay, and then the product of those two is multiplied by a conversion factor. And that is set by CMS every year. It can go up, it can go down, and then that gives you your dollar figure. So that's how much you're reimbursed. So for doing the exact same work, the reimbursement can vary depending on where you live. You may get higher reimbursement, again, in Chicago where I live, with the idea that it costs more to do it here. But the idea is it's supposed to be relatively even in what, I guess the urologist ultimately puts in his pocket for the doing the same work. I mean, doing a cystoscopy in one place, you really should be ultimately take home the same amount of money doing it in another place.
Okay. Well, can you expand upon what RVU based physician comp models could look like? How would they work?
Sure. Yeah, I think many people are familiar with this. That the idea behind that is, RVUs are measurable, right? Everything that we do, you submit a billing sheet, or it's done in your electronic medical record, or you put a CPT code. Or it may be multiple CPT codes. And that happens if you see somebody in the office, or do an office procedure, or do a procedure in the hospital. And it's relatively easy to measure, right? I mean, I suspect most people in practice can get a report that says this is how many RVUs you generated and this is how you generated them. So I think it can be done a lot of different ways. Many people are hospital employed, whereas many people are, still have a private office. But I think the RVU is utilized in both settings. For example, in a hospital employed, you may have a straight RVU model, meaning and with a dollar figure for RVU. For example, in urology, I think that figure is typically between $50, $55, something like that. So the math is simple. If you do 10,000 RVUs and it's $50 per RVU, that comes out to $500,000. So that's pretty easy. You can argue whether that's the fairest way to do it or not. So I think there are some variations on the theme. So you can do what's called a graduated payment scale, meaning that if you're making fewer or you're producing fewer RVUs, the value may be lower, but as you increase the number of RVUs, that you get a higher dollar per RVU. With the idea is that I think that can incentivize people. Well, if I work harder and I produce more RVUs, my compensation's going to go up. So it's used kind of as an incentive thing. And then I think there are a number of hybrid models where you may get a base salary, okay, that you're guaranteed to get X number of dollars, and then above and beyond that depends on your RVUs. So again, if you produce more RVUs, you're going to get a bigger slice of the pie. I'm in academic medicine, so we're really more the first model where it's sort of a straight up RVU. And there's plenty of data out there. There are organizations that tabulate this stuff and relate it to payment. And might say, well, at this number of RVUs, this would be the I'll back up a step. They may say the 10th percentile of RVU production for a urologist is X number of RVUs, and then the 25th, and then the 50th, and then the 75th, and then the 90th, and then show a corresponding salary with those percentiles. So the idea is that if you work at the 50th percentile, this is kind of what you would expect your salary to be. And I can just tell you that in my institution, that's the way it's done, that this is your RVUs, this is where it puts you from a percentile rank, and this is the typical salary for somebody in that range. And again, there's adjustments. For example, salaries may be different where I practice as opposed to where someone else practices for kind of a whole host of reasons. So there is some geographic variation in terms of those tables. So, for example, I practice in the Midwest, so our tables theoretically encompass people that practice in academic medical centers in the Midwest, and then there are similar data sets for private practice and that sort of thing.
I just want to say thank you very much. You've taken a complex system that especially younger urologists who are coming out, starting practice, have sometimes a difficult time understanding and just the background of the RVU. So, what take home messages would you have for our listeners today to understanding RVUs and the importance in both reimbursement as well as physician comp?
Sure. So a couple things. One, it's a complex system. I've been involved with it on the AUA level for a decade, and I still learn stuff every year. Um, I think the RVU is here to stay, whether we like it or hate it. It's here to stay. So I think it behooves all of us to, to try to understand it. And I think many, if not most, compensation models incorporate it to some degree. So there's really no escaping it. So common question I get asked is, what can urologists do? And I think the most important thing or the most important take-home message is to please answer the surveys, answer them honestly, and really give thought into how long it takes to do things. Because you're essentially being compensated for your time. And so you really want to think long and hard about it. The surveys don't take very long. They're probably 15 or 20 minutes, but they have huge ramifications. And now you will be asked at the start of the survey whether you do the procedure. And if you don't, then you're probably not the best person, quite honestly, because if you have partners that do it and that kind of stuff, maybe, but generally you want to answer a survey on a procedure that you do, because then you have the most intimate knowledge of the work that's involved and the time it takes to perform those work. And remember the three components of the pre-service work, intra-service work, and post-service work, because all of those things do take time. Now, again, as I said, it's here to stay. There are people that will argue that RVU-based compensation is not particularly physician friendly, but I guess, as I said, it's here to stay. So I think the better understanding we all have it, we can hopefully use to our advantage in terms of negotiations and that sort of thing.
Well, definitely. Well, I'd like to thank our audience, our listeners, and definitely like to thank you, our guest, Dr. Turk.
Well, thank you very much for having me.
Invest in your leadership and business skills at AUA 2023 with the new AUA Institute for Leadership and Business track. Join the Institute at the AUA annual meeting in Chicago for an opportunity to grow your leadership and business skills. The new ILB track features 7 courses, offering a combined total of 16 hours of programming that will enhance your business acumen, activate your interest in business and finance, and inspire you to become a leader in your practice and the field. To accommodate the robust schedule of AUA 2023, each of the 7 live courses will be recorded for access on demand after annual meeting. Resident discounts are available. Visit auanet.org/AUA 2023 to learn more and add the ILB track to your registration.